Today we're going to be covering kidney disorders and the therapeutic management of those kidney disorders. This is found in Chapter 27 of your 7th edition Critical Care book. And so let's get started. All right, so to begin with, acute kidney injury is a relatively new term that describes the spectrum of acute onset kidney disorders that can range from mild impairment of the kidney all the way up to acute kidney failure, and that requires renal replacement therapy or dialysis. Severe acute kidney injury is characterized by a sudden decline in glomerular filtration rate or GFR, with the subsequent retention of the products in the blood that are normally excreted by the kidneys. And this causes three primary disturbances. Number one is electrolyte balance disturbances. Number two is acid-base homeostasis. And then number three, fluid volume equilibrium. Those are the three important factors that you need to consider for your nursing care whenever we're talking about renal dysfunction: is electrolyte balance, acid-base homeostasis, and fluid volume equilibrium. And critical care patients with acute kidney injury do have longer lengths of stay in the ICU. They have more complications and they have a higher risk of dying. And the risk of dying is actually anywhere between 15 and 60%. Today, the most frequent cause of acute kidney injury in the critically ill is usually associated with sepsis or cardiac surgery. Typically, a patient is not admitted to the critical care unit with just an isolated acute kidney injury. There's usually a coexisting problem with the cardiac system, the pulmonary system, or the neurological system. And then the patient subsequently develops acute kidney injury because of a problem like that. Now, depending on the patient population, you may see that the patient develops acute kidney injury, or they may actually have a underlying kidney injury or chronic kidney disease that becomes worse because of an underlying illness. One of the challenges of estimating the incidence of acute kidney injury in the critical care unit has been a wide variation in the definitions, and there's a new way to kind of define acute kidney injury, and it's referred to as the Rifle criteria. And this is just an acronym that stands for risk, injury, failure, loss, and end-stage kidney disease. So that's just simply an acronym that refers to the spectrum of kidney injury, all the way from the risk, identifying a patient at risk, or identifying a patient that has end-stage kidney disease. This criteria can help to determine, or excuse me, it can help to evaluate the risk of a patient when they are admitted to the ICU, and it can also help to determine their mortality and morbidity. Okay, previously, acute kidney injury was defined as or referred to as either pre-renal, intrarenal, and post-renal. And these definitions are still used in the clinical setting. You'll hear people talking about them. And so let's break this down. So any condition that decreases blood flow, blood pressure, or kidney perfusion before the arterial blood reaches the renal artery, then that is referred to as a pre-renal acute kidney injury. Now, if something actually happens to the kidney where a toxic insult or ischemia to the parenchyma of the nephron, or so I think I defined parenchyma. This is just simply the actual tissue of the organ. In this case, we're talking about the kidney. If damage to the tissue itself is caused, then that is referred to as an intrarenal problem. So, for instance, a medication, if a patient, or contrast, if a patient's kidney is injured because of contrast, that would be considered an intrarenal type of kidney injury. And then finally we have the postrenal, which is an obstruction that hinders the flow of urine from beyond the kidney through the remainder of the urinary tract, leading to what's called a postrenal acute kidney injury. And there's a couple of terms that we talk about. One is azotemia, and the other is uremia. These are synonymous terms, and it simply means that the patient has an elevated blood urea nitrogen, and this is one of the signs of acute kidney injury, although it's not a very specific sign. Okay, quick question. Any condition that decreases blood flow, blood pressure, or kidney perfusion before arterial blood reaches the renal artery that supplies the kidney may be anatomically described as which kind of acute kidney injury? And if you remember from the slides just before, you would know that that would be question A, or I should say answer A would be the correct answer. That is a pre-renal condition. Okay, now let's talk a little bit about the laboratory assessment that we're going to be doing. Patients with acute kidney injury need to have their acid-base balance measured, and after acute kidney injury is suspected, the degree of injury can be assessed by the serum electrolytes and also the level of acidosis in the blood. Now, on table 27.2 in your book, lays out the normal serum electrolyte values, and then 27.3 lays out the urine laboratory analysis information, and then table 27.4 lays out the serum electrolytes in acute kidney failure. Acidosis, defined as a pH less than 7.35, is one of the trademarks of severe acute kidney injury. And metabolic acidosis occurs as a result of the accumulation of those unexcreted waste products. The blood urea nitrogen level is really not a reliable indicator of kidney injury as an individual test, but you can use the BUN to creatinine ratio, and that can be calculated to determine the cause of acute kidney injury. The BUN to creatinine ratio is most useful in diagnosing pre-renal acute kidney injury, in which the BUN level is greatly elevated relative to the serum creatinine level. So the serum creatinine is creatinine is a byproduct of muscle metabolism and is completely excreted when the kidney is functioning normal. But when the kidney is not working, the creatinine level will rise. And even if there are small increases in the creatinine, this can actually indicate a significant decrease in GFR, or glomerular filtration rate. Serum creatinine level should be reassessed daily, and the trend is really what we're looking for when we're following that. The urinary creatinine clearance can be measured if the patient is making sufficient urine, but obviously if the patient is anuric, then that would not be possible. A normal clearance rate is 120 milliliters per minute, but this value decreases with kidney failure. Critically ill patients with severe kidney injury will manifest elevated serum creatinine levels and may also become oluric. And because of this, the creatinine clearance rate is rarely measured in critically ill patients. Another test that can be done is the fractional excretion of sodium, or FeNA, in the urine, and this can be measured early in acute kidney injury course to differentiate between a pre-renal acute kidney injury and an intrarenal acute kidney injury. If the FeNA value is below 1%, then this suggests a pre-renal compromise. And however, if diuretics are administered, the test becomes meaningless. If the FeNA value is greater than 2%, this implies that the kidney cannot concentrate the sodium and that the damage is in the kidney itself, or intrarenal. Urinary sodium level can also be looked at, and if the urine sodium concentration is less than 10 milliequivalents per liter, or this would be low, this would suggest a pre-renal condition. And then if the urine sodium level is greater than 40 milliequivalents, this would suggest a intrarenal. And it makes sense that if the sodium level in the urine is high, that means the kidney cannot reabsorb that, and indicating that the kidney is not working properly, which would be intrarenal. The incidence of chronic kidney disease in the United States is about 10%, or 1 in 10 people. So it's relatively common, and it is associated with older age, and there is an association between acute kidney injury and heart failure. Among adults older than 60 years, the prevalence of chronic kidney disease is actually closer to 25%. And there is a correlation, or there's basically a tandem relationship between those patients who have diabetes and hypertension and the development of chronic kidney disease. There's also a strong association between kidney failure and heart failure. Moving along in the systems, there is also a significant association between respiratory failure and kidney failure. In studies of critically ill patients with kidney failure, over half of those have respiratory failure as well. And mechanical ventilation does alter kidney function. Acute kidney injury increases inflammation and causes the lung vasculature to become more permeable, and often these patients can also present with acute respiratory distress syndrome. And then patients with acute kidney injury are more likely to require prolonged mechanical ventilation. Sepsis does cause almost half of the cases of acute kidney injury in critically ill patients, and sepsis and septic shock create, as we discussed in previous lectures, create hemodynamic instability, reduced perfusion to the kidney, and as well, there's an immunologic and toxic factors that cause inflammation and then alter the function of the kidney at the microvascular and the tubular levels. There are clinical practice guidelines for managing the hemodynamic support of sepsis patients, and you learned the latest guidelines for those last week, or actually 2 weeks ago. And as well, we have to remember with trauma patients, they have an increased incidence of acute kidney injury, and this is primarily because of a drop, well, at least for the younger patients, when they have hypoperfusion, then that's going to lead to a pre-renal type of acute kidney injury. With older patients that may have underlying chronic kidney disease, they may have hypoperfused state, and it may take very little hypoperfusion to actually induce a full-blown acute kidney failure. Oop, we went one far. Another thing we have to consider is contrast-induced nephrotoxic injury. Patients who receive, actually 1% of patients who receive radiopig contrast will end up developing acute kidney failure and will require dialysis. So whenever we're taking care of critically ill patients that are receiving CT scans with contrast, we need to ensure that they receive proper hydration. And the hydration is best done during and after the procedure. There are also other medications that we can give to help improve or decrease the risk for acute kidney injury because of contrast, and that would be we can give sodium bicarbonate to alkalinize the urine, and this does there is some belief that this may protect the kidney beyond just normal hydration with saline. Another thing, we've talked about this many times, but if a patient has a catheter associated, or if they have a catheter in, then they are at risk for developing a CAUTI, or a catheter-associated urinary tract infection. And removal, although it's important to measure urine output and get accurate, fluid volume status, getting those tubes out as soon as we can is very important. And the hemodynamic monitoring, daily weights, and the actual assessment will help to more clearly identify the patient who may be developing acute kidney failure or acute kidney injury. Daily weight is an outstanding method for determining this, and as you all know, 1 kilogram of weight gain would indicate 1,000 cc's of additional fluid retention for a patient. So now let's talk a little bit about electrolyte balance. 2 of the primary electrolytes that will help us to, or that we need to ensure that we replace or that we get rid of in the body, are potassium and sodium. Let's start with potassium. So potassium can quickly reach levels of 6 milliequivalents per liter or higher in a patient with acute kidney injury, and specific electrocardiographic changes can be seen, such as peak T waves, a widened QRS complex, and also ventricular tachycardia or even ventricular fibrillation. Hyperkalemia can be treated temporarily with intravenous insulin and glucose. The insulin basically drives the potassium back into the cell, and the glucose prevents a low blood sugar. And so this is a temporary measure. The long-term measure would be to give potassium binding resins and or dialysis, so that the patient, the potassium level will remain low. Both hypernatremia and hyponatremia are associated with increased mortality in kidney failure, and the serum sodium should be monitored closely with patients who are in kidney failure. The serum calcium levels are reduced in kidney failure due to multiple factors, including hyperphosphatemia. So chronically elevated serum phosphorus levels above 5.5 is associated with higher mortality rates in patients with kidney failure, and most calcium in the bloodstream is bound to protein. Calcium levels can be measured in 2 ways: the total calcium or the ionized calcium. Unfortunately, protein calcium binding confounds the measurement accurate calcium levels. So the metabolically active non-protein bound portion is known as the ionized calcium, and this is actually the preferred measurement for calcium level, and it's called the ionized calcium. Maintaining adequate calcium stores in the body is achieved by simply administering calcium supplements and also giving vitamin D. So that's how you're going to replace the calcium. A second method can be used in tandem with calcium supplements to achieve a normal calcium level. Phosphorus occurs in foods, and after ingestion, a medication binding agent may be administered orally or by nasogastric tube to bind the dietary phosphorus. These are called phosphorus binding agents. The 3rd generation binders are known as aluminum non-calcium based medications. They can include such medications as Renagel or Fosrenol. These medications have a good safety profile and frequently are prescribed to lower the phosphorus levels in patients with chronic kidney disease. So the treatment goals for patients with acute kidney injury are focused on prevention, compensation for the deteriorating kidney function, and regeneration of kidney functional capacity. The key treatment areas include prevention strategies, fluid balance anemia. So the key treatment areas include fluid balance, addressing anemia, medications and electrolyte replacements. Effective prevention requires an acute injury risk assessment and knowledge of the most frequent causes of acute kidney injury in the critically ill. And medications with nephrotoxic side effects should be avoided in these patients. And non-steroidal anti-inflammatories for pain relief are to be avoided because they can actually increase the creatinine level and damage the kidney. Let's talk a little bit about the medical management now, and in particular the fluid resuscitation of a patient in acute kidney injury. And what we're talking about here is the pre-renal patient, a patient who comes in and is hypotensive. These patients are at risk for pre-renal failure, and that's because of the low perfusion state and a decreased perfusion to the kidney. It is often associated with trauma, hemorrhage, hypotension, and major fluid losses. Also, one would be burns. We're going to be by this point, you will have had your burn lecture. And if contrast dye is used, aggressive fluid resuscitation with normal saline should be given. And the objectives of volume replacement are to replace the fluid and electrolyte losses and to prevent ongoing loss. And so maintenance intravenous fluid therapy should be initiated along with, if it's possible, to give oral fluid intake when the patient is able to do that. So there are two types of fluids that we sometimes talk about, and that would be crystalloids and colloids. And both these fluids can be used to manage the volume in a critically ill patient. Crystalloids would be things like normal saline, half-strength normal saline, lactated ring ears, and then colloids would be things like albumin 5% and 25%, or hetastarch. Those would be some examples of a colloid. Now, acute kidney failure results in retention of water, solutes, and potential toxins in the blood, and measures should be taken to decrease the levels of these toxins. Diuretics can be used to stimulate the urine output in the early stages of acute kidney injury, and ultimately, if a patient goes on to is unstable, they may actually require renal replacement therapy. Diuretics as well can be used to stimulate the urinary output, and there are three main types. We have our loop diuretics, the thiazide diuretics, and osmotic diuretics. Loop diuretics include such drugs as Lasix and Bumex, and these work by blocking the sodium, potassium, and chloride transport into the nephron on the ascending limb of the loop of Henle, where most sodium is reabsorbed. This type of diuresis is also called natriuresis, in which the sodium is excreted and water will go with that. Diuretics from different classes may be prescribed in combination. So a thiazide diuretic, such as Diuryl or Zeroxolone, may be administered and followed by a loop diuretic to take advantage of the fact that these medications work on different parts of the nephron. And finally, osmotic diuretics, such as mannitol, can be prescribed to increase urine output and decrease fluid volume overload. Mannitol is filtered by the glomerulus, and it is not absorbed by the nephron, and it works in the proximal tubule and also the descending section of the loop of Henle via what is referred to as aquaporine water channel. And here are a few other types of diuretics. Only one carbonic anhydrase inhibitor acts as a diuretic, and it can be used in very specific clinical circumstances. This drug is called Diamox, and it acts on the proximal tubule where it inhibits the carbonic anhydrase enzyme, which allows for more bicarbonate to be released into the filtrate, and this results in an alkaline diuresis. Now, Diamox is administered to treat the metabolic alkalosis that sometimes occurs following aggressive diuresis with a loop diuretic. And spironolactone, which I'm sure you all have heard of, is a potassium-sparing diuretic, and it inhibits the aldosterone mineralocorticoid receptor in the late distal tubule and collecting duct of the kidneys, which causes potassium to be retained and sodium to be excreted. At high doses, it has a diuretic action, although that is rarely the rationale behind its use today. There is a new class of medications that are collectively referred to as Vaptans, and it inhibits the effect of antidiuretic hormone or vasopressin on V2 aquaporine channels in the collecting ducts of the kidneys. Now, blockage of the aquaporine channels renders the collecting ducts impermeable, resulting in solute-free water, excretion, or aquadiuresis. Vaptans are used to correct symptomatic hypervolemic, hyponatremic dilution states. The clinical intent is to eliminate water and retain sodium. So that's really the goal, or what these are used for, is to eliminate water and retain sodium. So here's just a picture of the renal capsule and the Bowman's capsule, and then the entire nephron and where diuretics work. And you can see that, well, let's start over on the right side. We have our Vaptans in the collecting duct and the distal tubule. We have our potassium-sparing diuretics in the distal tubule, and then our loop thiazide and loop diuretics in the distal tubule as well. And then the proximal tubule would be our osmotic and our carbonic anhydrase inhibitor diuretics. Low-dose dopamine previously was referred to as renal dose dopamine, used to be frequently infused to stimulate blood flow to the kidneys. However, research has shown that although it does increase the renal blood flow, it doesn't actually improve kidney function, so it is not really indicated anymore by the research. There is a drug, and it's an anti-inflammatory agent known as N-acetylcysteine or Mucomyst, and it can be used for many, or it has been used for many years as a mucolytic agent to assist with the expectoration of thick pulmonary secretions. But it can also be prescribed for patients with mildly elevated serum creatinine levels before radiologic studies where they're receiving contrast dye, because it has been shown to have a mild protective effect against contrast-induced nephropathy. Also, the dietary phosphorus binding agents must be taken at the time of the meal. Those are just something to think about, is the timing of those dietary phosphorus binding agents. So now let's talk a little bit about nutrition and some of the nursing management. So diet or nutritional supplementation for the patient with acute kidney injury in the critical care unit is designed to account for the diminished excretory capacity of the kidney. And so what we're talking about here is we're going to be thinking about what we need to limit in a patient, and then what we need to replace in a patient. So oral nutrition is preferred if possible. Fluids should be limited, and monitoring of blood glucose is recommended. And the electrolytes that we're thinking about limiting are going to be potassium, sodium, and phosphorus. And the electrolyte that we're going to be thinking about replacing is going to be calcium. Some individuals are at increased risk for acute kidney injury as a complication during their hospitalization, and patients at risk include older persons, dehydrated patients, patients with hyperperfused kidneys, patients with increased creatinine levels, and like before they came to the hospital, and then patients that are undergoing any kind of a radiologic procedure where they're going to get contrast. So those are the patients that you're going to be thinking about for having an increased risk of acute kidney injury. And then patients that are in the ICU have a risk for infection, and patients with acute kidney injury sometimes have an even more increased risk. So it's something to be considered. And remember, make sure we get those the urinary catheters out as soon as possible. Some of the key factors with fluid balance, electrolyte balance, and then preventing anemia we're going to discuss here. So with fluid balance, we want to make sure that we monitor urine output hourly. That's one of the major things that we're going to be doing. And any fluid that is removed from dialysis should be accounted for in the patient's intake and output. And you should understand and know the signs and symptoms of fluid overload, and also reduced fluid volume status. And then, of course, you need to understand the signs and symptoms of hyperkalemia and hypocalcemia, hyponatremia, hyperphosphatemia, and then acid-base imbalances. And we already talked about hyperkalemia. The big one is there. On our EKG, we may see peaked T waves. With hypocalcemia, we may see a muscular, we can perform Chopsticks and Trousseau sign. This is going to be, the patient is going to have kind of a tetany, and they're going to have muscle spasms. Hyponatremia, we're thinking about mainly just getting the lab value, and also if the patient has a change in the level of consciousness, this can be caused by hyponatremia. And then hyperphosphatemia, the patient is going to have that muscle spasm. And then, of course, with acid-base imbalances, we're going to be monitoring the arterial blood gas for that. So anemia is another expected side effect of kidney failure. And often patients who are anemic will receive the medication erythropoietin to basically replace their own body's ability to create that hormone. The kidneys are the organ that actually make erythropoietin, and so that has to be replaced because it no longer produces it, or it produces it in very small quantities. So the normal erythrocyte survival of 80 to 120 days is decreased. So the erythrocytes that are made in patients with acute kidney injury are not as robust. And gastrointestinal bleeding is a possibility in acute kidney injury. So we may be monitoring, we should be monitoring the stool for blood. And then patients with acute kidney injury may also need to receive iron supplements, B12, B6, and also folate to help with the anemia. We're going to just address some patient education information. Patients should be educated about their acute kidney injury, and the key factors that you want to discuss with a patient is their prognosis, the current treatments, and possible complications. It can be fairly challenging to discuss this information with a patient, and depending on their receptiveness, you just have to be tactful and do the best you can. So now we're going to talk a little bit about hemodialysis. So there are two types of renal replacement therapy that are available for the treatment of acute kidney injury. And the first would be intermittent hemodialysis, and then the other would be continuous renal replacement therapy. Intermittent hemodialysis is performed in patients who are stable, and then renal replacement therapy, continuous renal replacement therapy, is performed in patients who are unstable. And again, we're talking about the reason we're doing this is to remove the toxins and fluids and electrolytes that are built up in the system, in the patient's body, because of the acute renal failure. This is just a diagram of the renal dialysis, the filter, and I'll just let you take a look at that for a minute. And this is the filter unit for dialysis. Fairly complex system. Usually you as a critical care nurse won't be the one that is managing the intermittent dialysis unit, but you very well might be managing the CRRT, or the continuous renal replacement therapy. Some hospitals allow their critical care nurses to get trained to perform this, and it is very labor intensive. This is just basically a picture of a standard temporary vascular access, and you can see that so you have a double lumen catheter, and on the upper picture we can see that on the very top that's the fluid that is coming from the pump and hemofilter, and then the lower portion is to the pump and hemofilter. Fairly straightforward. And this is just venous access. This is not a arterial venous access like you're going to see on the next picture. And this is, again, temporary. This would be a permanent vascular access. These are two different types. The top one is referred to as an AV fistula, and the bottom is an AV graft. So the medical management of a patient receiving renal replacement therapy involves the decision to, number one, place the vascular access device, and then to choose the most appropriate type and location for each of the patients. For critically ill patients, they're going to be receiving a temporary device, and if they go on to develop chronic kidney failure, then they will receive a permanent access device. Continuous renal replacement therapy can go on for usually several days, depending on how well the patient's kidneys recover, and it can be, and usually it is. You go from continuous renal replacement therapy over to intermittent dialysis. And the patient's blood flow is 100 to 200 cc's per minute, and the dialysate flow, it ranges between 20 and 40 cc's per minute. And so you can see that that's similar to the glomerular filtration rate, and you would then expect that the patient's acid-base status, their electrolytes, and also their fluid balance would normalize. And the three things that I mentioned are exactly the three things that we are always trying to monitor and get to normal whenever we're talking about acute kidney injury. And again, just to repeat that, it would be electrolyte balance, acid-base status, and fluid volume status. The next slide is just a running list of the terminology for continuous renal replacement therapy. I'll let you look up the definitions of those things on your own. And next slide, we have just a little discussion of the modes of continuous renal replacement. And there is this mode called slow continuous ultrafiltration, or SCUF. This is simply where what is being removed is simply fluid alone. There is no removal of electrolytes, just fluids. And then we have continuous veno-venous hemofiltration, and this is actually where there are fluids and solutes that are removed. Another type of continuous renal replacement therapy is CVV-HDF, or continuous veno-venous hemodiafiltration, which combines two of the previously described methods of dialysis to achieve a maximal fluid and solute removal. This is just one of the mechanisms. This is often the one we use in the most critically ill patients, and it does give you the best results for electrolyte balance, fluid balance, and then acid-base balance. I think that's all I want to touch on related to renal replacement therapy. I will mention about peritoneal dialysis, just to give you a heads up that some patients actually do their own dialysis at home with peritoneal dialysis. So you have a dialysate, an infusion of that dialysate into the intraperitoneal space, and then it's allowed to stay in the abdomen for a time to basically draw out the fluids and electrolytes into the peritoneum, and then you have the drainage of that fluid. And this is a picture of what that looks like. And depending on some patients can manage their own fluid and electrolyte balance with peritoneal dialysis, and it is an option. Here's just a close-up picture of the peritoneal dialysis catheter, and as you can see, although it is tunneled inside the subcutaneous tissues, there is a risk for infection because you have a hole in the skin that ultimately goes into the peritoneum. So monitoring for signs and symptoms of infection is important. Okay. So I think that concludes this section, and I'll let you all review the summary information. You can go through that. And next up, we're going to be discussing